Good evening, everybody, and welcome to our Judy Nicholson Because I Care panel.
Tonight's discussion is sponsored by Merck and Exelexis, so a very special thank you to them.
I have the privilege of then introducing the panelists and am so appreciative of you all being willing to join us on this evening and then to support this initiative to both provide information and support to our patients and caregivers with the Judy Nicholson Foundation. I will start with Emily, will you introduce yourselves and tell us who you are and how you're affiliated and then if and how you're tied to kidney cancer.
Yes. So my name is Emily Williams, and I joined JNF almost 2 years ago, back in 2024. And how I got involved with JNF is my uncle, he sadly passed away with kidney cancer a few years ago. And then I know Victoria, and yeah, that's how I got connected. And I'm currently finishing my last year of law school. So I'm doing that in Dallas, Texas. Yeah. And I serve on the board for JNF. I am the marketing officer. So yeah.
Welcome and thank you again for being available to us on tonight. We look forward to the discussions that'll come forth. What about you, Dan? I'm going in order the way you all show on my screen.
Thanks, Jayla. I'm a clinician that's been in the mental health and hospice and palliative care field for about 45 years. I'm still teaching as an adjunct professor at the University of North Florida, and Jayla asked me to join, and I bring my experience with hospice and palliative care services and supporting families from a clinical perspective and also program development.
Wonderful. Thank you, Dan. Welcome again. And what about you, Miss Rachel?
Hi, I'm Rachel Mack. I'm a nurse practitioner at Mayo Clinic in palliative medicine. I've been in palliative for about 10 years. J-Lo is my mentor. My first year, she took a chance and taught me everything that she knew, I hope, everything that I know about palliative medicine. And I'm here as a guest to speak to caregivers, and I'm excited to be here. Thank you for having me.
Thank you, Rachel. All right, and Miss Kathy.
Hi, I'm Kathy Russell, and I'm a caregiver. I came to Judy Nicholson about 3 years ago in search of help, found the Facebook group, and my day job, though, I am a hospital administrator for one of the state of Michigan's state psychiatric facilities. And right now we have adults and youth. So my husband was my warrior, and he recently passed away, but I am still going to be as involved as I can be with Judy Nicholson because the information and the support from this group has been phenomenal.
And you are our warrior, alongside still carrying that torch and keeping the mission going. So we're so appreciative of having you with us on tonight and just a part of the group.
I forgot to say, I'm the fundraising chair for Judy Nicholson. The director of development, also known as fundraising.
Yes, she comes up with some great ideas. We did music bingo recently, so if a virtual group with that, indeed, check that out. That was a good one for us as well. All right. And I see a couple of our guests that are on this evening. I don't tend to want to put you all on the spot, but I always open the floor if you would like to say hi and tell us a little bit about either yourselves or your relation to either kidney cancer journey or caregiving. So I'll just open the floor. It's optional. You can just say hi and move on from there if you'd like, or if you'd like to say a little more, we open the floor for that. Hi there, James. Would you like to say hi and do any further introductions with us? Oh, you're muted. Threw you for a little curveball there. I'm sorry. You see a little microphone? There you go.
Okay.
All right.
All right. Yeah, I'm a patient. I was diagnosed back in October of 2017, or 2018, I'm sorry. I instantly for a prostate treatment, and then they did it after the biopsy. They did a CAT scan, and they found that I had kidney cancer. And my left kidney removed in December of 2018. And so far, so good. I did have a couple relapses. In 2022, I was put on Yervoy, and I forget the other combination. And I pretty severe reaction to that. And then I was put on cabozantinib for three and a half years. It worked great, but just back in January when I had a CAT scan done and an MRI, they found that it had spread. So
Okay.
now I'm on and Lenvima.
Okay.
I just had a CAT scan or a scan done again 2 months later, and before I was on the Lenvima, and now I'm on the
All these big names. It's a quiz, just about, isn't it?
Belzutifan. I'm on Keytruda, and the
Okay.
Keytruda combination with Lenvima was working because my tumor shrank. But now, since I couldn't tolerate the Keytruda, I'm on this other regimen now.
Okay. This is the part when they call it practicing medicine. It's not because you're so much, and I know trials are out there, trial medications and things of that nature. You're not so much a guinea pig, but we do have to see how your body responds to the treatment. And
I
then
feel
just
good.
me.
I really feel good. Yes, some small side effects, but other than that, I'm energetic. I did get a little tired, but other than that, I feel good. I got a good appetite and stuff.
Thank you for joining us on time. Welcome. Yes. What about you, Ms. Antonia? Antonia?
You guys hear me or you freeze?
You froze, but we can hear you.
Do you guys hear me?
Yes, we can hear you well. There you go. Now you're unfrozen.
Okay. I'm sorry.
Yeah.
Because my internet here might be unstable.
Okay.
Yeah.
Sorry.
So I'm a patient. Yeah. I got diagnosed at the age of 37 with
Okay.
stage 3 chromophobe renal cell carcinoma, so kidney cancer, but one of the more rare subtypes. I had surgery to remove my right kidney and the fat tissue surrounding it. And that was my only treatment. This was back in November 2023. So it's been 2 years since then. So far, oh good. No comment. I was pregnant at the time.
Okay.
So my only symptom was high blood pressure. But so I actually got admitted to the hospital because they thought I had preeclampsia. But after I delivered the baby, randomly, like I started getting fevers and like I got a sharp pain on the right side. I thought I have a kidney infection because everything else was coming in back negative for all the tests they were doing. It turned out to be we found like randomly by an ultrasound of the kidneys that it was a mass on the kidney. They didn't know at the time whether it's cancer or not. Only after the surgery, once they removed the kidney, the pathology report, we found out there that it was cancer, but the biopsy we did before that was inconclusive. Anyway, so that's been 2 years ago. My baby's fine. I didn't have to give birth at 31 weeks, 5 days, and he spent 6.5 weeks in the NICU, but I feel like he saved my life because if it wasn't for what happened during
Yeah.
like I would probably never know that I had kidney cancer until it was too
Right.
late.
Yeah, kidney cancer is
So
sneaky
I
like
joined
that.
in- Yeah. On the last one, I heard about the Judy Nicholson Foundation, and that's when I started following guys and getting all the emails. So my goal is to attend all the talks since I used to have an opportunity to learn about what's going on and anything useful. I mean, hopefully
Awesome.
not any treatments, but we'll see.
Awesome. Continue to keep in here and keep in contact. Definitely look at some of our patient open forums that we have too. So we have panelists and sessions like this, symposiums. We do in-person dinners and sessions in different states so that we can try to meet our constituents and our patients and families that are affiliated with this. So definitely keep in touch and go ahead and get involved and get engaged with some of our open forums for our patients. Was like Matthew and James. Yeah, that would be awesome. We'd love to connect with you more directly.
Yeah, and I forgot to say that I live in California, Santa Barbara, California. I work at UCSB, the University of California, Santa Barbara. And currently I'm doing like surveillance. So every 3 months I get scanned to check if anything's like, if everything's still good or if something's showing. But hopefully things keep getting good.
You said knock on wood. Tap you. Okay. Yeah. Awesome. All right. Karen, would you like to say hi or again, no pressure. All right. What about you? Oh, there you go. Go ahead, Karen.
Currently have a sinus infection, so I sound terrible.
Oh, bless you. Okay.
Yeah, I was diagnosed in May of 2023, bleeding. I had a urinary tract infection, ended up with kidney cancer, papillary. aggressive. Had a nephrectomy. Returned 2 months later. I was stage 3 originally. I started on Opdivo and Cabometyx and did really well with strength for 9 months. Had a reaction to Opdivo and got colitis in the hospital twice. So it took me off of that. And ever since I've been on just Cabo, different dosages. I went down to 20, 5 days a week, and now I had some growth, OLBO progression. So I'm back on to 40, 20s, and now I have scans in 2 weeks. I've been doing pretty well, but it had spread to my VC and lymph nodes and retroperitoneal lymph nodes. But I feel great and
Awesome.
doing really well. So Dan show because there's less treatments for papillary, so I'm trying to stay on the Cabo as long as I can.
Yes. Good. And to have been a patient for, I say it's a short amount of time, but a good amount of time. You seem like you definitely soaked up a lot of information and gotten very familiar. So it's important to be good, to be knowledgeable and to be your own advocate. So that's important that you do that. So awesome.
This group and the stage 4 group and the Cabo group learned the hard way.
Wonderful. Thanks for joining us, Karen. Appreciate it so much. Tammy, what about you? Would you like to say hi?
I didn't know either. It was this panel. I didn't know we did.
All right. And then Linda and Victoria, I didn't give you all a chance to say hi. Do you wish to say hi and do introductions? And then we'll move into That's Linda Anderson. Go ahead. You're muted.
Hello, I'm Linda Anderson. I'm the CEO of the JNF Foundation. Thank you all for attending. Thank you all for participating. Really appreciate it. If there's ever anything we can do for you or you need help with something that you're not getting help with, you can email us. Hey, you can go right to the website and hit contact, and it'll talk the rest of the right. That's what I'm here for.
Wonderful. Thank you. Yes, absolutely. And then Miss Victoria, what about you?
Hey everyone, my name's Victoria. I'm also a board member with JNF. I'm the treasurer. I've been involved for about almost 3 years now. My dad had kidney cancer and unfortunately passed away from it. But shortly after that, I got connected with Judy Nicholson. And we've been volunteering and helping out ever since. And I'm also a law student with Emily, and we're both graduating in, I think, 34 days, 36 days. So
do the countdown, girl. Do the countdown. Yes. That's awesome. All right. So this forum tonight is called Because I Care. And the reason we say that is I can't tell you as a clinician how many times I've been asked, how do you do this? Why do you do this? How this has got to be tough, especially when you work with such acute patients. When you're talking about cancer patients or patients with really chronic illnesses. You heard Dan and Rachel and I talk about palliative medicine. You've even heard the word hospice. And a lot of times when we're talking in our groups, we're encouraging our patients and families to have palliative providers included as a part of their care teams in the hospital, not because of the hospice component or talking about that end of life piece, which a lot of times people associate that hospice portion with, but it's to have a translator, so to speak, throughout that continuum. But the reason I always come back to is it's because I care. And everything that I do, both in my professional world and personal world, hence my involvement with the Judy Nicholson, I don't get paid. This is not a paid position. This is not a paid role. I've been engaged with not only the Judy Nicholson team, but this cancer community. We do our caregiver support groups. And it truly is because I care. And when I talk to different caregivers who are struggling because their loved one is either being stoic or not engaging in some of the tough conversations throughout their cancer journey, the patient may be saying, but I don't want to be a burden. And the caregiver is saying, but I care. I'm here because I love you. I care. And so it always becomes this common theme, whether you're the caregiver, whether you're the family member, whether you're the healthcare provider. I think a common theme that I hear is at the end of the day, a lot of this is all because we do care. And as an organization, we wanted to pull that forward and acknowledge. So I asked everybody to just do the introduction and either talk about how the kidney cancer journey, whether you're the patient or the caregiver, how that starts, because that helps us also identify who our active group here is. But remember, because this is going to be something we use and can have in our archive for some time, we want to be able to make sure that we're addressing and speaking about these things as it relates to all of our patients and family members and other providers who may be gleaning from what you all as professionals, but also as patients and caregivers have to say. So for the panel, one of the first questions I'll ask the group is, do you just in general have a mantra that gets you through the day or through, because not every day as a caregiver or a patient family caregiver or as a clinician, we a lot of times are absorbing a lot of that, both emotional, physical, psychosocial component of caregiving from a professional standpoint. Do you have a mantra or anything that helps you navigate or get you through your regular work day or what have you?
I'll go. And this one came actually when I was looking to prepare for the last the last symposium in Williamsburg.
Yes.
And it was actually from a song by Willie Nelson, and it was about somebody passing away. The song was.
Okay.
But I also feel it this way in dealing with cancer and kidney cancer is that this is not something we get over, but it's something we get through.
Absolutely.
And every day was something we might have to get through. And my husband had problems with the cabo, and he was on Nebo initially and ended up in liver failure. So we got through that. And then we started a different medication and a different regime. But then of course he had colitis from that. And so we got through that. We will get through whatever is thrown at us. But you're never going to get over it because once you have this diagnosis, I think it's going to forever be part of your life. Look at, my husband was diagnosed on March 29th of 2022. That became a new starting point for us of what our reality was moving forward. So we got through all of that.
Yes.
But it's not something you get over.
Right.
But we will get through it. And
Yes.
and like I said, he passed away in February. I'm getting through it. I'll never get over him. I'll never get over that. But I will get through whatever the next step is.
Absolutely. And part of what you're saying makes me think of I know Dan and Rachel, some of the lingo that we hear a lot in our field. And people say, I hope this and I hope that. We hear that word hope a lot. I hope I never am sick. I think everybody can hope for that. But what we say too is that the more you're educated and learn about the journey, but also take one foot and put it in front of the other and just continue to learn, continue to approach and not be fearful of the what ifs will come, whether we're talking about your kidney cancer diagnosis or what today holds, what tomorrow holds, but knowing too that hope changes throughout the course of that, the more the realism of what you're facing, but also the bigger picture, that your family bonds or your family relationships, embracing and allowing people to love on you. And that goes again for both the patient and the caregiver. That's every component, every piece of that. And the realization and what I hear from most people is you never lose hope. The hope changes throughout the course and it becomes more tangible and more real through every new hurdle that you overcome, even on the tough days. And so I think that's always a good place to remind yourself that every hurdle is there, but you got folks like us and your medical teams who are helping to push you over that hurdle when you're not feeling your best to be able to do that, even as caregivers. That's again, that can be for everybody. Rachel, I see you unmuted.
Oh, I've been on mute. I've just been listening, but I just want to add to that. The thing when people say I'm very hopeful, I always hear in my head that hope is not a plan. And so because I want to help you try to plan for these next steps, but I also always tell my patients and my families that being hopeful and being realistic are not opposite ends of a spectrum. They can very much go together. And so sometimes, like you were saying, Jayla, we have to redefine what we're hoping for within the context of the disease and of the prognosis, but there's always something to hope for. And so part of what I enjoy about palliative medicine is helping people find what there is to hope for. And then
Absolutely.
use that as a plan.
Absolutely. One of our board members, Walter, I think he's 20 plus years through his cancer journey. And I love for him to be able to share and say that as well, because oftentimes, because kidney cancer is one of these diseases that is so subtle and doesn't make a big fuss until it is metastatic where it's spread to other areas. it's one of these diseases that kind of creeps along and progresses silently. Antonia, is it Antonia or Antonia? Yes.
Antonia or
Antonia.
Tony.
Antonia spoke about being pregnant at the time of her detection. And so all of these things are unexpected. Life has its way of sending us down different twists and turns. But what's always important, I always tell my patients too, you're the driver. I'm either shotgun in the passenger seat or in the back. I'm somewhere in the car. But ultimately, you're telling me which way we're going. I'm just here to guide you and give you some options. And so part of that is it was like I was saying to James earlier, when a lot of these medications have been widely successful for many patients, whereas others we hear, gosh, I went on Keytruda or Cabo and like literally 1 or 2 doses had to stop right away. Our body's going to respond different to things, but part of that care team that you're with, and I hope to God you all have really supportive teams who take the time to explain things to you, who talk to you, don't rush the visits, and make things really make sense. Because in this health system today, everything is moving faster. And you just can't, though, replace that human touch and that part of it. And for me as a clinician, that's one of the reasons and ways because I care that you understand, I care that the details matter, and that all of this comes together so that when you're an informed decision maker and you understand, what your body is doing and is not doing and why, then that helps you and your family manage and navigate that. Dan?
One of the things that I learned from working with people that had serious illness or had a terminal illness and were facing their own death was, how do you make every breath count? And one of the things that we always tried to teach our staff to help patients and families was make every breath count. And that takes a lot of different kinds of forms, but you can get caught up in the medicalization of an illness and everything becomes about the treatment of that illness. But there's also the life that you are living, and how can we help you make every breath count as
Yes.
best we can.
Absolutely. I think Kathy said it earlier that she is a clinician, and I can't remember I know you said she mentioned that corporate side, but dietitian, she's very knowledgeable about a lot of things. But even as the provider and knowing all the things, that having to switch hats sometimes, even to make sure you're giving yourself the opportunity to be the caregiver when you're the caregiver, the patient if you are the patient, and knowing these things, but then also knowing when to pick up what you know about the industry and or the field altogether. You unmuted, Kathy, before I go to the next question. Go ahead. Did you have something?
No, just in case.
Okay. Then I'll start with you if that's okay. What tips have you learned or what really helped you through your caregiver journey, both while your husband Tom was still here with us, but even in hindsight, what do you credit as some of the things that have made this loving journey, even on the days where he may not have been as lovable because he's frustrated, or maybe you were frustrated and he needed the patience and what have you to be, if those days exist, like what do you credit as some of the tips that you
Always try to keep that communication open. And so many tips have come from the Judy Nicholson Facebook groups. It's so helpful to have a community of people that actually know what you're going through. And I know I could never, even though I knew my husband very well and we were together for 45 years, I knew he wasn't feeling good. But I really and truly, as a caregiver, I can't know how he was feeling because I'm not in his body. I'm not feeling the same thing he's feeling. So please talk to me, tell me, so keeping that communication open. He was stoic, like you say. He didn't want to bother me. He didn't want to make me worry. I worried anyway, so it didn't matter. Tell me what's really going on so I can either, if we need to call the doctor or the care team, or I can get you some water or an Imodium, whatever it is, but you got to talk to me. So making sure to keep open those communication is so important. But also taking time for yourself as a caregiver, as a patient. I continued to work after his diagnosis so that he because I'm that helicopter mom or helicopter wife, I'm going to be there and I'm going to be asking, can I get you something? Do you need something? What do you need? Can I help
You've
you?
got to keep busy
know,
almost.
And I needed to allow him, and it's hard for me to give up control like that, but I needed to allow him to be independent. And if he wanted to say something, he would. But so again, mainly keeping that open, but also taking time for yourself. Work for me, it's not my idea of, it's not like a week on the beach. It is it's a respite for me from the caregiving. I have a wonderful team of people that I work with, and laughing and playing, or not playing, but laughing and talking and venting and crying if I needed to. I have my people that I can do that with. But just making sure when I went once a month, I would still go for my massage just to make my body feel good, and taking a walk and crocheting or reading and keeping those kind of things, to not give up on my life completely, just to center around the patient,
Yeah.
which that would be my what I would want.
Wonderful.
I also knew that wasn't going to help him a whole lot, because if I neglected myself, then I would be neglecting him in the long run.
And 45 years together, you know him like a book and he knows you. And so even when you're holding back different emotions or not saying everything you may be thinking, you two intuitively have, and others can relate to that as well, have that instinct together where you can tell when somebody's uneasy, and I don't just mean physically not feeling well, but there's something there. You're quiet, you're different. What are you saying? What are you not saying? Are you upset? Are you happy? Just really being able to cover those things. Antonia?
Yes, I just wanted to offer like a perspective from a patient about the
Yes.
palliative care teams. Because I remember I was in the hospital. I had to stay in the hospital for about 3 weeks because I was right after the birth of my child, because I had developed this infection, or now I think it was just the cancer fever showing up. But I had the fever for 3 weeks, and they eventually, once they found the big mass on my kidney, they sent the palliative care team to my room. And I was so mad. And I wanted them to leave my room, and I even kicked them out. Because I feel like that was very preemptive on my side. I just want to give you that perspective, and maybe it's
Yes,
coming
please.
stereotype. But since some of you guys work in palliative care, I think it's very important to approach the patient when they're ready to receive any advice. Because I was like, why are these people here? I'm not dying. This is not even, we don't even know if it's cancer yet. I was not in the mental state to talk to them. And I was so mad that they kept coming to my room. And I was just, at the end, I just kicked them out. I was like, everyone,
Oh, we froze. I don't know if you can hear us.
I'll talk to you. Leave. But the reason I approached the right way, or I wasn't ready to process it. And also, like, it was before I was even diagnosed officially. So I was like,
What are we talking about?
preemptive.
Yeah.
Yeah. And I understand they were sent because, okay, most likely this was cancer, and they could see that. And
Yeah.
I knew that too. But I wasn't in that stage able to talk to them. And I was like, I'm not dying. Why are you guys here?
And
it's
it's
like they're making me feel so bad about myself.
and I appreciate you
It's not their
sharing.
fault. It's just like their whole presence, like the idea. You came to my hospital room multiple times. I was just like, I don't know. Like, I was very mad at them. Like,
Yeah.
but like, it's not their fault. I think they were just doing their job. It's just, I think
A lot
of just being a little bit more sensitive, like with patients who are like, maybe they're not terminal, or they haven't been told they're terminal, or like the diagnosis is not official. Like, I don't know.
So what I'm hearing that I appreciate you sharing this perspective, in many hospitals, especially around the country, so not just talking Florida where we are, or just around the country, a lot of palliative programs are either synonymous or are truly hospice programs. When we're speaking in this scenario or in this context about palliative, and I get it, I don't know the individuals that came to you, they may have been talking more from the, oh, this is bad, this is prepare to die thing. And I'm here.
And they weren't saying that. I think they were more on the palliative side. They weren't hospice. Because like they were trying to make that clear to me, but I just wasn't ready to like listen to them. And I was like, I don't need you. I'm not dying. And that was just my perspective, because obviously I didn't know very well the difference between palliative care and hospice and all that stuff. So in my mind, they were blurred. But for me, it just made my anxiety and depression like skyrocket by their presence, like by them even showing up. Like I wasn't ready to die. And I ended up never needing them. But I guess they were just offering their services and explaining what they do. And most of what they were explaining was not hospice. It was just like, exactly, if you're dealing with a chronic illness, like this is the stuff, like we can help you with this or we can help you with that. Or we can provide these support services. And I was like, maybe like my advice or tip would be wait until the patient has processed a little of what's happening.
Yeah.
Like maybe after they're released from the hospital, like they can connect with them and see if they need anything. But not when they're still in the midst of it, like day-to-day
shock and awe.
survival. Yeah, the shock. And
Yeah.
they're still doing I was just focused on one day at a time going through the day. I was not in my mental state of being able to like even think about, oh my God, like they're telling me I could die from this. Or even they were not saying that, but it was just like, wow.
It's a realization. It was a realization, and that just cemented it for you. And believe it or not, and I'm glad that you were, and I know you said I didn't kick him out like that, but if you needed to, that's
I went to the doctor.
yeah.
Like,
I don't think I was a true palliative provider, and I'm raising my like palliative sensitive and understand that there's moments when you are not ready to have that conversation. There's also others who are so overwhelmed with hearing they need a sounding board, and we never know which version of patient you're going to get. So you make yourselves, even when I'm not in a palliative role, I'm always thinking, and that's that caring part of it. I know some things about me as a nurse practitioner, period, palliative or otherwise, medical things and questions, even in our groups. It's so helpful because some of our caregivers and patients have been through different experiences. And part of having the support group, a lot of times when we're doing the caregiver groups and the patient forum groups, we're there to moderate, but really you all, the patients and caregivers and caregiver to caregiver may say, this is what I'm experiencing. Kathy does it all the time on some of our groups. She'll say, oh, try this balm or try this ointment. Or sometimes you all are able to share nuggets with each other, not because you're experiencing it right at that moment, but they may be telling you about something they've come through or come out of. And that's really the goal or hope. Even with what we do in these forums, you'll hear us talk to some of our caregivers and or family members that may speak of a loved one that passed. And for some people, even when we've been on some of our caregiver groups, they may opt to jump off because it's like, ooh, I'm not ready to talk about that part. And our goal is not just to talk about the death and dying, because we have so many of our warriors who are thriving, who are doing well, who glean from each other. How did you gain weight? What did you do for the nausea? So we continue to do what we're doing because we see the benefit of that. And we understand that fear, regardless of the cancer, whether we're talking kidney cancer, breast cancer in and of itself is a hard word to palliate or to digest and go, oh my gosh, me, especially at 37, especially as a brand new mom, all those things that you already
I think I was just in the shock of
facing.
it. And
Yeah.
I was just not mentally in the capacity to have that conversation. Now, obviously now I'm 2 years removed, but even let's say a few months removed was a different story. Like after I had spoken to my oncologist, I had gotten a bit more understanding of what the type of cancer is. 2 months later, I was like, okay, I mean,
Now we can do.
yeah, exactly. But at the hospital, when I was just learning about this and like going day to day surviving about, I mean, not even knowing if this cancer is or not, I thought it was a little bit preemptive for the hospital staff to send, because they would just send to my room. I guess it was part of like their. And
I don't like when they do that, because I say to people, I've used the analogy, actually one of my physician partners one time, not directly working with me, but we had a similar scenario where, and I'm not talking palliative right now, I'm talking just general. We had some information that we needed to share with a family that it was not cancer related, but it was not going to be great news, obviously, in this scenario. But the doctor was like, I just got to be straightforward and just blurt it out. And I think we've heard those scenarios, and in your head, you're like, no, not like that. And so what I told the doctor, what I said, the scenario I gave him, I said, $100 steak is $100 steak, whether you serve it on a gold platter or a trash can lid. It all matters. The delivery matters. The conversations matter. And that gold platter that I'm going to prepare that steak on has to have some caring and some compassion behind it, whether it's a palliative provider, whether it's a regular physician, whether it's a social worker, a nurse at bedside that day, the CNA, the neighbor who's going to come over and help you with your medication, or like whatever, whoever is going to be a part of your and or your loved one's journey, they have to care. They have to care and not get so caught in the mundane or get so complacent or used to the care environment if it's a provider that they lose that sensitivity to gauging which patients, families, caregivers do I need to lean in on and provide more support, emotional, psychosocial, or otherwise, and which ones do I need to give time? Because if you all, especially those of you who are married, you can tell when your loved one is in a good mood or not, or if you've got to have a difficult money conversation, or let me tell you what the kids did conversation, you know they're going to be upset. Timing matters because when and how you decide to deliver this news or have this conversation, we can take it outside of cancer. Anytime you've got to have a challenging conversation, there's got to be timing is going to matter, not so much all the time what is said, but how it's said. Because I can say good morning 5 different ways, and it's going to make you feel different ways. So again, all of these things are important, and these are things that we encourage people to family. I've even talked on the group about when family members that can feel tension between each other, caregivers. One of our caregiver groups, it was a mother-daughter group, and they're like, some days we just don't want to talk, or I know if I say certain things, I'm going to be walking on eggshells. So we talked about keeping like little index cards around where maybe you write a question on the card and put it in a little receptacle, and the other person picks a day, a time, or what have you. And when they are ready to maybe not have a verbal conversation, but read what you asked or your thoughts, and then on the back respond respond that way. Sometimes it can soften some of the conversations and take some of the either anxiety and or frustration out of the moment. But again, to all of what you said, I hope the team that you were dealing with in the hospital and or at any time after, palliative or otherwise, were receptive and understanding of your feelings and emotion at the moment and didn't make you feel that you shouldn't feel the way that you did feel. Because I do want to validate that as well. That was a lot of information to digest in a very short time. A 31-week baby who your mind is in 1,000 different places and having to digest this new mass that's been discovered. No, so please know,
Yes, sir.
I appreciate you sharing that because I always like to make sure people know. I don't want people to be afraid of the word palliative, but I also want you to know you are a part of the care team. So it's appropriate to say, not now, not today, and or lean all the way in. It just depends on, again, more times than not, they're there for questions to translate some of the overall medical information that's being shared, because sometimes different doctors use all the big words and some doctors speak only about their part of your body and these other doctors talk about their part of the body, but you are one body and somebody has to make sure we're talking as that full representative. And then of course, symptom management, if there's pain or nausea and other symptoms, to make sure you're educated about the medications and or options to help manage those things too. So it's all of those things without so much that bigger, tougher, is this the end kind of a question that may or may not come at this phase of your care. I thought I saw. Yes, go ahead.
I hope I wasn't, obviously, I hope I wasn't like very rude to them, but I was like, when I
You could've
apologized,
been,
I
you
feel
need-
could have been at that time. It's just I wasn't like ready to have that conversation, but
Sure.
I do think they're very helpful, especially now that I know a little bit more about what they do is key.
That's okay. And you listen, you responded the way you needed to, I'm sure. And I'm sure that would be fine. Kathy, did I cut you off? Were you saying something?
No, but so my view with palliative care, they say in cancer care it's curative treatment or it's palliative treatment. And I have my own term for that, which is controllative. So our palliative care team, they helped us control pain. They helped us control nausea. They helped us control some of the symptoms. And because I heard palliative care too. And even as a medical professional, my mind immediately went to hospice. And I'm like, wait, we're not there yet. But when we talked with the doctor from the palliative care, is okay, so she's not dealing with hospice or end of life. She is dealing with, let's get his pain under control. They become my controllative team versus the palliative team, because they're helping us to control all of those negative side effects or mental health issues or financial toxicity issues or whatever. So palliative care is a wonderful thing, but when Antonia is brand new is, oh, wait a minute, and you haven't been around enough people with this disease or the cancer to understand that there's different phases of palliative care. And
Yeah.
we were thrilled with our palliative care team, but once we knew what it was.
Yeah. And this is all about learning. I know, I promise you this because I care. And I know that because Dan and Rachel and I and others have had experience with palliative, this, because I care, really is not geared to say you have to have palliative and or hospice. What we are saying is, from the provider standpoint, is the benefits of all of that conversation, knowing that that there's compassion behind, even with our we have oncologists, and even on some of the patient forums, so some of our oncology partners and nephrology docs and urology docs that would jump on and do different in-services. I was doing a in-service a week or so ago, just discussing the kidneys and how they do function so that patients and caregivers understand the role of the kidneys and how so many things in your body. How can my body feel so bad when the kidneys just make urine? And it's no, they do more than make urine. So let's talk through some of these other things, because by better understanding that, then it helps make some of these other symptoms and things that patients may experience, make some of those things make more sense, but also anticipate, all right, when I'm on this medication, if I'm having some of these side effects, because we know bowel incontinence and some of those other things may come along with these medications. How do I manage that? How do I stay hydrated? How do I maintain my nutrition? How do I make sure I'm timing my pain medications properly so that I'm not having other issues during medication management or symptom management? And again, even our physicians, our oncology, urology, nephrology partners that work with us on the Judy Nicholson Foundation, the reason they are frequent flyers with us and called upon often is because not only are they knowledgeable, but they have that caring spirit. They take the time to talk with our patients and families one-on-one in the symposiums. They don't run off as soon as they get off the stage, they stay. And that's an important thing too, because when I was asking that earlier, it was for that purpose, to make sure that you have a care team, that you feel confident that you are heard, that they are able to answer questions for you, and that you and your family feel validated when you have a concern or a question. Again, that's that care and compassion. Some people can be taught it, but really it's ingrained in others. And it's important that we tap into that and ensure that care team is looking at all those options or support needs we're anticipating things that you haven't encountered yet, so that we have a plan already in place or ready to address that with you. All right. One more question here, and then I think we and Leslie now open the floor for any questions from you guys. And believe it or not, we're about 10 minutes from our designated end time. So we'll try to keep that on task. That time, in my opinion, went by quickly. But are there any, I think we talked a little bit before about from the caregiver perspective, but as far as soft care balance, I always say you can't from an empty cup. You have to find time. Kathy hit it on the head when she talked about massage and having it days where she's able to recharge, refuel. What are some of the key balances that you feel you have been able to do, or that have been helpful for recharging? And how do you inspire other caregivers and or patients to do the same without feeling that they're taking away from their loved one by doing so? Two-part question. How have you balanced or identified or found that balance? Emily, how about you? Can I come to you? Were you actively involved in your uncle's care or your parents?
No, but I guess I've witnessed a few caregivers in my life. And I think one thing, can you hear me? Am I okay?
Yes.
Okay. And I think one thing that kind of caught me off guard with witnessing the caregivers in my life is realizing that there needs to be like just an acknowledgement of, okay, I need to stop and slow down and say, I need to take time for myself. And so I think with figuring out that balance, I think that's the first step that I've mentally noted for just the caregivers that I've witnessed is just stopping and saying, okay, I need to take some time and figure out what that looks like. and what you can do. And so I think, I don't know, that just came to my mind when you were asking the question, is the first step being, let me acknowledge that I need to start the balance.
Yeah. Yeah. Absolutely. And we've had caregivers that would say, again, they're so intertwined and so ingrained into the appointments and the schedules and the medication schedules and all of that, that they'll say, I don't want to step away and take time for myself because he or she can't leave this disease. This is this ailment, this illness. But in the truth of the matter is, we would encourage the patient needs to, when they can, maybe they can't do everything, and you all can attest to that. There are some days you just don't feel up to any of your normal or what may have been your hobbies or activities. But then when you are, or redefining what those may look like, I think of Tom, Kathy, when we were celebrating him in his golfing trip with some of the buddies. He was so excited about being able, and we were excited to hear him being able to do it. I knew that was something he had looked forward to and had a wonderful time. But again, pacing himself and being able to take his time, but enjoy it and know that he deserves it just as well as that caregiver. And it doesn't mean that you care any less because you have to acknowledge that I need a break. And it's not acknowledging that the other person is a burden or creating any kind of challenges. We know role reversals and things may come into play when one of the family members are having issues or what have you, or when someone is sick. Those roles and tasks that they played in that family unit may change a bit, but trying to normalize that as much as possible so that that person doesn't feel that they are then a burden. Some people are going to feel that initially anyway, but the way of communicating and acknowledging the feeling so that it can be addressed and put to bed so that everybody can kind of continue open communication. We talked about that earlier, but I think that's an important part of that communication as well. Being able to say, I'm frustrated, I'm overwhelmed, but also I need time for myself. What else? I'll open it to the group. We've got about 5 minutes here, and I want to make sure if there's any other thoughts or from our patients, caregivers, and or providers, any other thoughts that you have that we haven't covered, or things that you recommend or find are key components of the caregiver journey. I think we covered the basis.
I'll say, just piggybacking on that, being a caregiver, I always tell my families that you have to take care of yourself in order to take care of someone else. And I think we feel like that goes without saying, but even on an airplane, they say, put on your own oxygen mask before you assist your child. And I want to assist my child first. I always want that to come before me. But if you're out of the picture, then you can't take care of your person. And so you can't set yourself on fire to keep other people warm. It's just, that's a hard stop. It's a cool one. Yeah.
That's the one.
I never heard that one. I like that one.
Here in the South, we got a lot of stuff.
Here.
So that's my personal mantra, is that I
Oh,
don't
that's
set
so
myself on fire to keep other people warm. But it just doesn't work. And so you'll burn yourself down. So you have to take care of yourself in order to take care of other people.
I love it. All right. On that note, I think that's a really good one then too. Look, we had a word from the night, one of our caregiver groups, and so you'll hear that again for sure. I'm borrowing that one. I think one of the other caregivers once shared with us. You remember the alligator in the boat, Kathy?
No.
Were you on that night? She gave me reference to some days you feel like you're in a boat surrounded on all sides by the alligator. What? Shoot the alligator closest to the boat. I said, got it. Get rid of that one first. That's your main one. These others will, look, you'll get that time, but we got tickled with that. But I do love that one. I appreciate everybody and your sharing on tonight. For our patients that have joined us, or do you feel there? We know many times that caregiving is built around your needs, and it is important. You're just as important in this because I care notion of supporting the caregiver who's supporting you, also vice versa. Those are two very important relationships. And obviously they wouldn't do it for you if they didn't love you, and you wouldn't be so protective sometimes of their feelings and or time and how they provide support to you if they didn't matter to you. And so are there any questions or anything from you guys before we wrap, or any thoughts?
Yes, thank you.
Wonderful. Wonderful. All right. Thank you so much, Dan, Emily, Kathy, Rachel. Thank you so much for joining us on tonight. We appreciate it so very much. And the Judy Nicholson Foundation, we exist because we truly do care about each and every one of you in our community as a whole. So from us to you, thank you so much for your time this evening. Join us on our Facebook page, follow us, and join us for our upcoming Celebration of Life. We'll be in Las Vegas later on this year. If you can make it there, join us. So follow us on the page and you'll get more up to date of our upcoming calendar.
Have a great night, everyone, and we'll see you next time.